advanced endoscopy at DDW.
Right, thanks very much. Thanks for having me and inviting me. It's a pleasure to be here, and thank you to the course organizers. So we're going to talk about the IES potpourri, not EUS ERCP. Didn't mean to make it rhyme, but there you go. So let's see if I advance. The green one. Oh, thanks. Sorry. Okay. So we're going to go pretty quick because what I reinforced going through the many abstracts is that interventional endoscopy, when I was a fellow in 2000, et cetera, was primarily EUS, ERCP, some luminal stenting, maybe Barrett's and colon EMR. Now there's a lot that isn't EUS and ERCP, and it's almost a whole year unto itself. So we're going to talk about complex colon EMR, bariatric endoscopy, reflux, Barrett's, and a touch of GPOM. So, but there was a decent amount that I had to leave out because of our limited time. So let's talk about colon polyp EMR, and we're really in the maturation phase of colon polyp EMR and optimization of outcomes. As you know, there's been a paradigm shift over the last 10 to 15 years of what really means unresectable when you look at a colon adenoma. And really, there's very, very few that are endoscopically unresectable these days. We're able to take out larger, more difficult lesions and even select cancers. And this has to do with the refinement of techniques to ensure efficacy and safety. We have better endoscopes to take a look at our margins and perform even assessment of pathology, histopathology. We aggressively ablate post-EMR margins, avulsion techniques to take out stubborn points of fibrosis, understanding and being more sophisticated with electrosurgical principles, more than just blue or yellow, as we used to say. And very importantly, recognizing and managing complications, including bleeding and perforation. Perforation used to be a do not pass go, to go directly to the OR with chagrin on your face. Now it's kind of a sigh and give me a clip and let's fix it. Okay, so the first one is about detection. This was a study out of our center, and it was a retrospective study of all referrals for EMR over 2 years. And what we found was that 10% of patients had additional polyps, and it corresponded that of all of the polyps, about 3% were missed completely on the index colonoscopy. And you would think that, well, those were kind of small, flat, sessile serrated polyps. Turns out they were fairly good size, with a mean of about 17 millimeters and up to over 2 centimeters. They were all sessile, however. They were mostly right-sided and mostly adenomas. There were no missed cancers, which is reassuring. But what this tells us is that if you're an endoscopist who's getting referred polyps to remove, be on the lookout for additional polyps. The referring physician may have found some and not taken them out, kind of given you the task, or may have missed it. And we know from tandem colonoscopy studies that we all miss polyps, but this is just an opportunity to achieve higher quality. The next kind of point in colon polyp EMR is that our modern techniques are effective even in difficult locations. And so the difficult location that this particular abstract out of Mike Bork's group looked at was the IC valve. And they did an interesting thing where they took this retrospective cohort, or this maybe historical cohort, and a contemporary or modern cohort, and they divided it based on when they started to use some of those adjuvant therapies I mentioned to you. And they found that their success of achieving eradication was significantly higher, close to 100%, with very little, less than 5% recurrence compared to their historical cohort. That's a big difference, 5% versus 20%. And so the conclusion there was that modern EMR techniques are actually better than historical techniques. Taking a quick side trip here, as you know, a topic of dealing with large polyp defects is potentially clipping, closing the defect to prevent bleeding. The delayed bleeding is the most common adverse event, can lead to rehospitalization, morbidity, and so reduction of that adverse event is of utmost importance as we do more of these. The routine use of clipping is controversial primarily because of cost and some discordant results with existing literature, including randomized trials. Most of us, however, would consider prophylactic clipping in high-risk patients, but what a high-risk patient is or a high-risk lesion is has not really been completely defined. So some of these abstracts try to tease that apart. This is a randomized controlled trial of prophylactic clipping after EMR, and it suggests that it's justified in the right colon, so that the right colon may be a high-risk geography. These are larger polyps, randomized 1-to-1 clip versus control, and significantly improved delayed bleeding in the clip group with a number needed to treat of about 14. They used about 5 clips each, so you can do the math of how much that's going to cost in your center. And not all had complete closure. Some of them had partial closure, but still had a benefit. The largest benefit was in that sweet spot of sort of medium-ish to medium, almost large polyps, and in the cecum. This was, on the other end of the spectrum, this was a subset analysis of serrated lesions from a previously randomized controlled trial of clipping of almost 1,000 patients published in 2019. That RCT showed a benefit of clipping, and this abstract looked at just serrated lesions that were fairly of good size, and they found no difference, suggesting that a serrated lesion, which you should be able to eyeball and diagnose, perhaps doesn't require clips. So the take-home points for colon management that I took from the DDW abstracts was we're starting to understand who we should, spend the money on to clip, and it may be lesions that are larger, right-sided, and adenomas. Careful evaluation of the right colon, even if you know you're going after a referred lesion, is important to detect synchronous lesions. And we have some tools available to accomplish improved ADRs that we routinely perform or use during the EMR procedure, such as retroflexion of the right colon and the use of a distal attachment cap. And finally, modern EMR techniques have matured or are maturing, and essentially there's really no such thing as a polyp that if you see it screening, you should send directly to your surgeon friend. It's worth at least an endoscopy or a discussion or FaceTime or send a picture to whoever you like to say, you can take this out, right? Before you go to surgery. Okay, so shifting gears to bariatric endoscopy. And the theme here is going to be some new techniques and confirmation of uses of endoscopic revision for bariatric patients. Obesity is expensive by any measure, as you all know, both financially and from a healthcare and morbidity standpoint. And as gastroenterologists and endoscopists, we're increasingly asked to be involved in the management of these patients. 10, 15, 20, 25 years ago, this really wasn't part of our tool set or patient panel. The way that we manage is initially a lot of this had to do with weight regain after prior bariatric surgery, including Roux-en-Y gastric bypass and sleeve gastrectomy. Primary therapy now is much more widespread and being investigated. Management of surgical complications, and increasingly gastroenterologists are using pharmacotherapy. So the most common thing probably is the TORI. This is a patient that's very typical, had a very dilated stoma that we've sewed down, and then a few months later is back to what you want it to be. Weight regain after bariatric surgery is very common. Up to a third of patients regain almost their entire weight, and TORI can result in, at 5 years, about 9% total body weight loss. Some surgeons are still a little reluctant to accept endoscopic revision, and so this abstract confirmed both the efficacy and the safety superiority of TORI against surgical revision in those with a dilated stoma. The adverse event rate was significantly higher in the surgery group, and at 5 years, the weight loss was equivalent. When we talk about primary therapy, there's a lot of folks that could benefit from bariatric surgery, but a big proportion don't utilize it. Only 1% of eligible obese in the United States undergo bariatric surgery. And so that's where primary endoscopic bariatric therapies come in. There's a lot of them. We're not going to go through them, but for your information. And a lot of these were based on the technology that you see there, the endoscopic stitching device, including the endoscopic sleeve gastroplasty. This is one of many series that look at an experience of consistently roughly 15 to 18% weight loss at a year or two. And this is basically forming plications intraluminally with the suturing device that you saw perhaps yesterday that Dr. Thacker presented. And so whenever we talk about endoscopic bariatrics, including sleeve gastroplasty, one of the criticisms is durability. And it's true that some can gain weight. And so this study was interesting because it looked at folks that had an ESG, and now it's old enough techniques and technology that the weight regain folks are coming back. And this showed effectively that a repeat ESG was more effective than pharmacotherapy at reducing weight. And so they got another 7% total body weight loss. This is a shift a little bit from using the endoscopic suturing device to now a dedicated device for applications in the stomach, the so-called POSE, that uses the scope just as an optical device, just as a camera, and produces these full thickness plications in a very standardized way to both reduce the length and diameter of the stomach, similar to a sleeve, just like as ESG would, but using a different method. And so this was the initial publication of the 2-year experience of 44 patients of this newer device, published by Abu Daya International, 44 patients. And this was used in the United States under an IDE. Relatively short procedure times. They used about 19 to 20 anchors, and they lost similar weight loss as ESG at a year or two with no serious adverse events. And they measured a couple of interesting markers, including steatosis. And they looked at 1 year at everyone, and all the plications were in place with still good volume reduction. So the take-home points for bariatric endoscopy is that endoscopic revision of gastric bypass is preferred first line, and in fact, you can revise also sleeve gastrectomies. Endoscopic revision of a sleeve gastroplasty is feasible and effective, and further adds to the appeal of that primary endoscopic option because you can yourself manage weight regain. POSE is a dedicated primary platform with good safety and efficacy with durability at 2 years. Whether it's worth investing in versus just using the old hat of the ESG is yet to be determined. So we'll move on to reflux. And the theme here is refinement of techniques and more experience in difficult patient scenarios. So why do we do endoscopic therapy for reflux? Well, it's a common quality of life disorder that I'm sure we all see every day. And there's a spectrum of disorders. On one hand, a lot of folks are fine with medical therapy. On the other hand, some folks need surgery. But there's a big niche, there's a big gray space where endoscopic technology can fill. In the past, though, endoscopic anti-reflux procedures have come under criticism for durability, failure to correct physiologic parameters, and so its role can be sometimes controversial. This is the most commonly used device or procedure. It's the TIF procedure that creates a esophagogastric plication with an endoscopically created partial fundoplication. So it's kind of a fundoplasty with partially a fundoplication. And we started to get interest in this at UCLA after some of the medium-term data came out in 2018, 2019, showing durability of efficacy at 5 years. This is sort of the study that everyone seems to quote with this technology and technique. However, over that time frame where this data had been developed and maturing, the TIF procedure was actually evolving to a somewhat of a weaker valve and application or a fundoplasty to something a little bit more sophisticated and involved. Initially, there was maybe a handful, for example, of fires and H-tags, and now we're routinely using 20, 30 or more. And in addition, the wrap component of it is much more aggressive than it was. And so these prior studies, one must ask themselves is, were they ineffective at physiologic control because we just didn't have the right technique down? And so that's what this study that Dr. Chang was involved with. This was the TIFF registry, led by Dr. Canto from Hopkins. It was a registry, it's an ongoing multi-center registry of using TIFF, and they specifically looked at this enhanced technique of really looking at a more aggressive wrap, a longer valve, multiple fasteners above the standard 20, and they found very much improved symptoms, but also they were able to demonstrate some normalization of pH data, and they had no serious adverse events. So this is early data suggesting that more aggressive techniques are effective. As I said, GERD is a spectrum, and in mild disease, medications are fine, and more severe disease, surgery is necessary, and that more severe disease tends to be defined by the anatomy of the gastroesophageal junction. TIFF is something that we look at when we have a Hill grade. This is the schematic of the Hill grade, if you're not familiar, that's relatively preserved in the 1s and 2s. Once there's a hernia or a very patulous with a faced His valve, His angle, then a hiatal hernia repair becomes necessary because of the laxity of the frontoesophageal ligament and some of the extra gastric structures. So it's generally a hiatal hernia repair plus something, and the something that we have seen increasingly adopted is TIFF rather than a surgical fundoplication. Either the surgeon goes on themselves and does a TIFF or hands off the case after the hiatal hernia repair to his gastroenterologist buddy before they go off and play golf. And so this looked at about 35 patients with larger than standard hiatal hernias that you would accept for a TIFF, up to 8 centimeters, and Hill grades greater than 3, and they followed those patients up short-term, up to 6 months. And they found success in both quality of life, reduction of PPI, and acid exposure. Whenever you're using a new technique and technology, when it fails, you also have to ask yourself, what are you going to do? And this series looked at that in a very interesting way. They looked at patients that had previously had surgical fundoplications, and they applied TIFF, and they found success, 100% technical success, which we weren't even sure before that we could do. And now also those that had gone back on PPIs, they had discontinued, and of the patients that had pH testing, all had normalized. So it's interesting, something that we hadn't thought about before. So our take-home points for TIFF, modern TIFF technique is safe and effective and perhaps better at objective acid control than historic iterations of the technique. And if a durable pH control can be demonstrated, this will be a big significant step advocating for its use. CTIF, C stands for combined, using the fundoplication combined with a hiatal hernia repair is emerging as a tool in the spectrum of reflux management in patients that previously were not eligible for TIF. And long-term and comparative studies are needed, but this is an exciting niche that endoscopists can be involved in. Finally, an interesting further niche is the redo situations. TIF appears to be feasible. We need to learn more about that. Shifting now into Barrett's esophagus. The theme here is pushing what we think of as endoscopically curable cancer and expanding roles of other ablation and resection techniques. So as you know, there's a progression in some folks of reflux to Barrett's to cancer, and so when we're talking about endoscopic eradication, we're talking about prevention of morbidity and mortality from esophageal cancer. And we have very good data, standard of care, of radiofrequency ablation and EMR. And we have emerging techniques of ESD and other ablation besides RFA that we don't know as much about. Radiofrequency ablation, to remind you, is effective and safe. And this study looked at using a cold technology, the cryoballoon, versus RFA, and it suggested that it may be just as good. The data is emerging. When you looked initially at the data, it actually favored the cryoballoon, but there were some confounding variables. When they corrected for those, they essentially got very comparable outcomes for both eradication of intestinal metaplasia and eradication of dysplasia, and they had comparable adverse events. So this is a step towards demonstration of equivalency, but I can say I'm not sure that we're quite there yet. When we talk about endoscopic eradication therapy, EMR is definitely a major component of nodular and raised lesions in early cancers, and it's easy, fast, and safe, and anyone can do it. ESD is fancier. It allows en bloc resection with the goal primarily of accurate pathologic assessment and staging with less recurrence. You can take bulky lesions out that perhaps you couldn't take with a band. And importantly, T1B cancers, meaning those with some superficial submucosal invasion, particularly in the upper third of the submucosa. So we're really getting into the granular nitty-gritty of this stuff with favorable histologic features, may be candidates for endoscopic eradication with ESD if particularly if they're not candidates for surgery. So this was in the Netherlands, kind of interestingly. Basically, everyone in the Netherlands that was doing ESD for Barrett's reported in, and you can do that in the Netherlands. You can't do that here since 2008. And they did ESD for suspicion of SM invasion or large bulky lesions that they couldn't resect. They had 130 ESDs, and they were fairly good-sized lesions. We got high-grade dysplasia and T1A lesions in almost half, and the en bloc and R0 resection was 87%. A little more than half, there was submucosal invasion. Some of that was deep, more than you would consider as curative. And their T1B en bloc R0 resection rate was relatively poor, 49%. And that makes us pause a little bit. When they did achieve R0 resection, there was no recurrence at 17 months. And R1 patients, they had some residual cancer, but they concluded that in those that they had residual cancer, even if it was R1, some of them, even those that went to esophagectomy, didn't have residual cancer present. So they were being perhaps a little bit, optimistic, but this demonstrates that we need to learn more about ESD and Barrett's neoplasia. This study demonstrated that select T1B patients, particularly if they have been demonstrated to have low risk, meaning superficial submucosal invasion, not dedifferentiated, and absence of lymphovascular invasion, did fairly well. And this is something that we all suspected, and this is adding to that data. And so these were usually cancers that if they were discovered by EMR as being T1B would be sent to the surgeons. And now we're learning maybe we can be a little bit more personalized about who we offer endoscopic eradication. So the take-home points for Barrett's, cryotherapy is emerging, and we need more data. The role of ESD in Barrett's is interesting, but it's hard to pin down. As someone who does ESD, and I love doing it, I try to be objective about it. You have to be really selective because it does take a lot more time, and there is a bit of a higher risk, though that's manageable risk. And finally, select T1B cancers may be managed endoscopically, particularly if someone's not an operative candidate, but that really requires a tumor board type discussion. And finally, a quick update on GPOM. GPOM is a endoscopic tunneled myotomy for gastroparesis. It would be lovely if every gastroparetic that had a pyloromyotomy was suddenly never hospitalized and never came to your office again. That's not the case. But out of all the therapies that we have available so far, this has been the most promising in terms of at least partial relief of symptoms. So this tried to quantify that. This was a meta-analysis of 20 studies with almost 800 patients. Only 2 of those studies were prospective. Their technical success was very high, 2 to 3 days in the hospital. Clinical success was about 7.5. But that's not clinical cure, and that's important to understand when you see these patients. It's a reduction of a symptom index, the GCSI, gastroparesis cardinal symptom index, decreased by 1.6, which that's a composite score. If you kind of look at that, that's not all that much, but it's better than what we had before. And those patients also had demonstrated objective measures of gastric emptying. An important take-home from this GPOM meta-analysis is there was no difference based on etiology. One of the main problems of GPOM is patient selection, and so this doesn't necessarily help us there. About 10% of adverse events were reported. And this was kind of an interesting abstract of a very specific population of folks, and this is something that we're getting involved in more at UCLA. Patients that get lung transplants often have vagal injury and vagal-mediated dysmotilities, including achalasia-like pictures and significant delayed gastric emptying that can lead to not just malnutrition, tube feed dependence, hospitalization, but reflux and graft survival threats related to accelerated rejection and deterioration of lung function. So 6 centers looked at 20 post-lung transplant patients. Most of these had previous intervention that failed, and they performed GPOM on them, and 85% had clinical success, with some, modest delayed adverse events that were manageable. About half of them had normalization of their emptying study, and a significant proportion of them were able to stop PPI for reflux dyspepsia type symptoms. And very significantly, of the few patients that had pH measurement that confirmed acid exposure in the esophagus, allowing the stomach to empty controlled their reflux better. So this is a cute little small abstract of 20 patients, but I think look out for this if you are in a center that has lung transplants. This is a major, major problem in their world, and we're going to be asked to manage it more and more. I've already done, I think, 2 or 3 lung transplant patients, and our medical director is now a friend of mine, has my cell phone, and we talk about patients all the time, to my great pleasure. So take-home points for GPOM. The data is expanding. More data is needed, including durability data and comparative data. Patient selection remains elusive. These are not achalasia patients that are very easy to diagnose, and they're homogeneous, and you take care of them and everyone's happy. It's a harder situation. And as we're learning more and more, gastroenterologists will be involved in lung transplant, and that this sort of gastroparesis is important in managing post-lung transplant patients. Thanks very much. Sorry for the rapid fire, but it's a lot to cover. I'd be happy to answer any questions. Thanks for having me.